Your next topic is cross-linking in Ectasia. When and how?
Due to the change in one of our speakers is unable to come. So I'm taking over this topic in behalf of Dr. Rajesh Sinha sir.
Yeah.
So I'm just going to give you just an overview of corneal cross-linking. So from its inception from the early 2000s by Wollensak and Theoseeler, this has been the gold standard method for stabilizing the cornea and preventing the progression, and Western protocol is the standard against which all other protocols has been evaluated. So again the question is whom to treat. So you have to see the pachymetry, you have to see whether there is a progression, and your topographer will help you in identify the progression as well with serial topography, and you have to also see whether there is a refractive error correction which is acceptable for the patient with glasses or with spectacles. Over the years, the criteria have changed. The progression criteria are very different. You can get an increase in keratometry, a deterioration in visual acuity, or a change in glass powers. But even now, certain studies have included perceived risk. That is, even without documenting a progression, if you feel there's a perceived risk, you can consider to do a C3R. Perceived risk may be one of the other eye, how the other eye has behaved, or what was the age of the patient. If there's a VKC patient you are dealing with who's having eye rubbing and progression, you can consider C3R with even before you document a progression. So as in this case, one eye is gone into full eye drops and scarring, the other eye is progressing, it's better to stabilize the other eye without waiting for any progression. In this case, one eye is slowly showing to show the keratometric changes, the other eye is relatively normal, but they are thin corneas. You can do the C3R in one eye and look for progression in the other eye as long as the vision is maintained. So the overall, what is being done, the Western protocol, you know that you put riboflavin drops over the eye, saturate the cornea, after which you expose it to 370 nanometers of ultraviolet air light, and once it is done, almost 5.4 joules of energy is transferred, and you give the BCL if it's an epi-off protocol, as in Western is an epi-off protocol, and give the post-op medications. So little bit about the photochemistry. There are two types of reaction, the type 1 and type 2. Whenever there is oxygen, the type 2 reaction occurs, which has a better effect, which has more controlled CXL. When the oxygen depletes, when it becomes hypoxic, it starts producing hydrogen peroxide, which is more toxic, and the effect is not stable. So whatever protocol you are going to change, these three things, this trinity will decide what is going to happen. That is fluence, how much riboflavin is diffusing, and how much oxygen you have. So whatever modification you can do in C3R is always influenced by these three things. So over the years, conventional protocol has been proven to be very effective, even in pediatric population, especially I'm saying pediatric because over 8 years, they can have a collagen remodeling and the effect may go, but even then, even our personal studies, we have seen that it has remained stable. So what are the modifications you can do? The accelerated protocols, the epi-on, epi-off, ionotophoresis, pulse CXLs, and the plus procedures. So the conventional protocol, the biggest problem is the duration. It's a long procedure, so it's a risk of infection. There may be uneven saturation. In uncooperative and difficult patients, hard to do it. So here comes the accelerated protocol based on the Bunsen-Rusko reciprocity rule, where the effect may be constant if the energy delivered is constant. In other words, by increasing the power, you can decrease the duration. But this is an inorganic theory applied on an organic body, which may not be applicable. If you see, the HEFIC group has done the study ex vivo, where comparing to the Western protocol, all other higher fluences have less stiffening effect. But over the years, accelerated protocol has been done and it has shown to be effective, but especially most of the 9 milliwatt 10-minute protocol seem to be the most effective among the protocols. This is one of the meta-analysis which I could see, and in the meta-analysis, except for BCVA and demarcation line, all other parameters have remained same between the conventional and the accelerated protocol. Even the BCVA, though it is better in conventional, the result is not significantly different. So moving on to thinner corneas, we have many options, but the most common option we use is the hyperosmolar cross-linking. Other options are the contact lens based or the smile lenticle based, and ionotophoresis and transepithelial. So hyperosmolar has also been tested over years and has stood the test of time. Only problem is, whatever method we are trying to swell up the cornea increase the stroma so that we can prevent an endothelial damage, but such swelling will cause an inadequate diffusion of oxygen, inadequate diffusion of drug, and the effect may not be as good as the standard protocols. These two methods, contact lens assisted and lenticle assisted method, have been tried. Most of these cases you have to realize is you keep a contact lens over or a lenticle over. After the procedure you remove that. So some of the cross-linking effect is not completely transferred, and although the oxygen diffusion as well as the drug diffusion may not be as even, and many studies have shown it's less efficacious than the standard protocols. Moving on to the epi-on cross crawl, the problem with epi-off is that you have to remove the epithelium, which is a risk for infection, it's a pain for the patient, it's an inconvenience to come back for the BCL removal. So that is one advantage going on epi-on. But any time you try to change the standard protocol, all these three factors gets influenced again. With the epithelium on, there is a significant reduction in riboflavin entry into the eye because it's a hydrophilic negative molecule. It does not just diffuse like that, but there is a reduction in oxygen because the epithelium consumes the oxygen, and the intact epithelium will also affect the fluence which is delivered. There we have introduced the method they have introduced the permeation enhancers, which are either alcohol, benzylconium, tramadol, or EDTA. Even the meta-analysis have shown over the years the epi-on is not as effective as the epi-off method. To circumvent this, ionotophoresis is one option they have done. Again, the negatively charged riboflavin can be introduced into the cornea by using an electric current. So we can drive the drug into the eye and saturate it and then do a C3R. In most of these cases, they have done an epi-on with a conventional protocol, but the problem is driving the drug inside does not mean that the drug will remain there, because the epi-off cases there is a passive diffusion of the drug which does not happen when it is epi-on. So the effect is again a little less compared to that of the normal conventional protocol. And in epi-on, again the fluence decreases by 30% and the oxygen consumption is by about 40%. To improve it, they have taken one more minute. Improve it, you can increase the fluence or make it pulsed. In pulsed, it's not a continuous delivery. The break time, the oxygen will replenish and you can continue with the C3R, or you can supplement oxygen from outside. So last two protocols, the sub 400 protocol popularized by Hafizi is for the extremely thin corneas where the protocol remains the Dresden. Only thing which is changed is after the saturation is over, the pachymetry is measured, and based on the nomogram, the time duration to which the radiation is given is adjusted individually as per the eye. And lastly, this is putting the refractive surgery part into the C3R, which the attempt is not to remove the power, but to regularize the power, improve the BCVA. The most popular protocols are the Athens and the Cretans protocol. Athens, where they use topo-guided PRK, and in Cretan, they use the PTK along with the conventional C3R. And when not to do, always remember, and if there is any herpetic disease which can be reactivated by ultraviolet, or in case of the steroid use, or any eye which poor epithelial healing, neurotrophic, severe dry eye, you have to you have to be careful in taking up such patients, and even VKC patients, you have to control the VKC before you take up for C3R. Thank you.
Yeah, Arjun, I think you've beautifully covered the cross-linking. So just to summarize it, I think even today the Dresden protocol is the gold standard, but the only issue is the practical issue of keeping the patient 1 hour in the OT. So what we have tried to do is the first half an hour, instead of putting in the OT, you can do the scraping over the slit lamp. Okay. And in the ward itself, you can instill the drops. So half an hour, at least the patient, you're not keeping the speculum, and your bed is also not blocked in the OT. But the next 30 minutes, definitely you do it in the OT. So in all the severe cases, we don't compromise. We still go with the Dresden protocol. But the borderline cases where you just want to be sure, I think those cases, a 10-minute one is a viable option that we can accelerated one. So I think that is one important. And whenever you're doing contact lens assisted, one more practical point is, most of the contact lens assisted by default have a UV filter. So you should make sure that the contact lens you are using for this particular thing should not have a UV filter.
Thank you.
Nicely covered, Arjun. Any questions from the audience? Yeah, please.
Sir, in the last procedures, what is the duration of the pre-soaking, like with riboflavin? 10 minutes only or 10 minutes?
Which one?
Riboflavin soaking, the easiest objective endpoint is take them back to the slit lamp and see if you see an yellow flare in the AC, that's good enough for you to go and start.